Thank you very much, Dr. Stadnik. Very happy to be here to present on what I call the incomplete puzzle of incomplete revascularization in CABG. This idea stemmed out from the fact that we have a very unique opportunity here at the Heart Institute from a trainee perspective to see very vastly different forms of coronary revascularization from a CABG, but also a PCI standpoint, especially with hybrid techniques. And so the question came to me one day when I was thinking, when we look at our angiograms pre-op, there are many ways to achieve a way of complete revascularization. And a question came to me in terms of, which strategy is better. And the more I looked into the literature, the more I found that the question wasn't quite clear. And so I want to show that to you guys today. And so we'll start with an overview of coronary artery bypass grafting. And then we'll chat about, what is incomplete revascularization and how is it defined in the CABG world. We'll go into a little bit of the history of studies that have been done so far, and then move on to studies being done today. We'll talk about the challenges of studying incomplete revascularization for CABG, reasons why surgeons would incompletely revascularize, and then possibly how ways we can mitigate it. And then finally, we'll talk about where we can go from here and what we can look forward to in the future. So an obligatory slide on leading causes of death. Coronary artery disease continues to be at the top of the causes. From 2000 to 2019, we can see that even that gap continues to increase. And really, I don't think we see that burden decreasing anytime in the future. Ways to treat coronary artery disease include coronary artery bypass grafting. First, we try to aim for medical therapy with primary and secondary prevention.
Sorry, Peter, I'm going to interrupt you just for 1 second. I think we've switched screens, so we can see you, but not your slides.
Okay, sorry.
No, that's okay. Somehow when we went live, we had a small technical glitch. I'm sorry to interrupt.
No worries at all. Let me...
Perfect. We can see your slides now. Sorry, carry
awesome.
on.
Okay. So we were kind of just passing here with the World Health Organization in terms of the burden of coronary disease, which remains to be quite high. And then we talked about different ways we can treat coronary artery disease, with one of the end-of-line treatments being coronary artery bypass grafting. And here you can see the most basic configuration in which we use the LIMA, or the left internal mammary or thoracic artery, to the main LAD, and then we have our vein grafts going to all of our other stenoses. So when is coronary artery bypass grafting indicated? Right now, CABG is indicated when we have severe multi-vessel disease, generally sicker hearts with a very complex disease often warrant coronary artery bypass grafting. These patients often have decreased LV function. They have high syntax scores. The syntax score is really just an algorithmic way of determining severity of coronary artery disease by coronary angiogram. Patients with diabetes, we know, often have more complex disease. And from our studies, mainly the FREEDOM trial, we know that there's a greater benefit for patients when they undergo CABG. And then for left main disease, we are there when the left main disease is complex and not favorable for PCI, especially with bifurcating lesions or lesions where stenting may cause high risk to losing the other branch vessel. We think that coronary artery bypass grafting, especially in terms of complex disease, provides revascularization through a different means than stenting, in that it provides flow beyond the flow-limiting lesion, but also helps with collateralization of non-flow limiting lesions distal to the main lesions. As well as it promotes angiogenesis. And so I think this is where we see benefits, especially in more complex coronary artery disease. Looking at coronary artery disease at the Heart Institute, and we're looking at our procedures here. When we include all procedures that are done on pump or even off pump, we're looking at almost 70% of procedures being done here, including one form of coronary artery bypass grafting or another. And when we look at isolated CABG, we're looking at around 55% of all our procedures. So this just goes to show the burden of coronary disease, but also how prevalent it is in our procedures. This is our main procedure, and this is what we are doing a majority of the time. Over the years, since the advent of coronary artery bypass grafting, we've developed quite a few changes and quite a few improvements in technique. And this started with grafting the left internal thoracic artery to the LAD. The very primitive forms of CABG, we saw vein grafts or grafts going to just myocardium, not even coronary arteries. And as we went on, we learned a lot more and found that the advantages of the lead to LAD were really not comparable to anything else. We then evolved and started doing multiple arterial grafting. We're able to do a lot of these techniques off pump, and even to the point where we don't even touch the aorta anymore for a few of our cases. Then we've also developed ways to use less conduit and do more distal anastomoses with sequential and composite grafting. And then we've evolved now to do minimally invasive CABG, as well as robot-assisted CABG, focusing more on patient-centered outcomes, pain, recovery, and so those improvements are also coming along. And then finally, we also have hybrid revascularization, in which we combine both CABG as well as PCI to obtain a better outcome for our patients. Realizing the importance of CABG, we're starting to see that coronary artery bypass grafting was kind of just seen as our bread and butter, and previously there was not a lot of focus on it. And so often surgeons paid more attention to more unique subspecialties of cardiac surgery, such as complex valve reconstruction, thoracic aortic disease, transplant, and mechanical circulatory support, and now adult congenital and arrhythmia surgery. However, I think we're starting to realize, given the burden of coronary artery disease, as well as how much it's changed and how much we can do with it, that coronary artery disease itself is being recognized as a subspecialty of cardiac surgery so that we can provide the best outcomes. So we go from the procedure on our left, which is what is offered to many people, to starting to come up with more creative solutions and more complex configurations on how to achieve the best outcomes in our patients. And so on the right here, we see utilization of three arteries, the right internal mammary, the left internal mammary, as well as the radial artery here, coming off the right internal mammary to extend it. And so we're able to do all of these bypasses with complete arterial revascularization. Here's just a diagram of, again, these are all different ways to achieve multiple arterial revascularization. And these are just really 6 configurations of a lot. There are many, many different ways to achieve what we want to achieve now. And the question is, which way is the best? So we'll jump into a case here. We have a 73-year-old gentleman. Your usual cardiac risk factors comes with an end-STEMI ejection fraction of around 50%. I'll run through a few angiograms here. So previously a shot of the LAD. Here we can get a better view of the circ as well as the lateral wall. A view of the right side. So just in case the the screens didn't run too well on your side of things. We have some pretty severe lesions coming off the ostium of the circumflex here. We see some disease in the OM along the length of the vessel. As well, looking down the LAD, we can see disease kind of prox mid, as well as on the diagonal here. Looking at the right side, there seems to be quite severe disease right in the middle here, as well as in our PDA. So if we divide our angiogram into a schematic here into 3 different territories, we have our anterior territory here in green, a schematic of the right side or inferior wall in our red/pink, and then blue representing our lateral wall. And if we look at the areas affected on the anterior wall here, we have our LAD and diagonal, our circumflex and OM, as well as our right and our PDA. So the question is, we can do a few different things here. On the left side, we can decide to revascularize by territory. And on the right side, if we look at where the lesions are, technically you have decreased flow distal to the stenosis in the PDA, but then you also have decreased flow even though there's no distal lesion here due in the PLV branch because there is limited flow in the RCA. Similarly, you have the same situation in the anterior territory as well as the lateral wall territory because of the proximal lesions. So do we revascularize with 3 bypasses here, or can we do up to 6? This is a picture of Steph Curry, probably one of the best shooters of all time in the game of basketball, with Fred VanVleet, one of our all-star point guards on the Toronto Raptors. And this is from 2019, better days for us. And you may be asking why I bring up the game of basketball in a talk about coronary artery bypass grafting. And it all has to do with defense and how we defend against players in basketball, but also how we defend in in coronary artery bypass grafting. So there are really 2 ways to play defense in basketball. The first, each person kind of stays in their zone, and no matter what, they kind of cover their zone. So, you know, each person is assigned to an area on the basketball court, and you kind of stay there depending on where the ball goes. You'll kind of move to different parts of your zone, but for the most part, you stay in this zone. In man-to-man or person-to-person defense, each person is assigned to whoever they're covering, and you stay attached to this person the entire game. And this is akin to what we see in what we can do here. On the left, we have a zone defense or a territorial bypass grafting. And on the right, we have a kind of a person-to-person plan in which each stenosis is covered by a distal anastomosis or a bypass in our strategy. So, you know, what are the advantages and disadvantages of doing one versus another? And really, is there a difference in clinical outcomes for our patients? Well, with anatomic revascularization or a bypass to every blockage that we think there's decreased flow, the advantages are that you're more likely to achieve more blood flow to the myocardium because you have more bypasses, and you're less likely to leave areas that we think may be left behind without enough blood flow. And so we think the ischemic burden is improved in anatomic revascularization. The disadvantages are that, as you can imagine, 6 bypasses versus 3, it takes a longer time to do them. So because you're often doing more anastomoses, you may require more conduit. And this can come in many different ways, either conduits that come from both sides of the chest wall, the left or right arm, as well as your legs, and in some cases even from the abdomen. And as you can imagine, this is more technically demanding. Territorial revascularization or zone revascularization is the most widely studied strategy. It's kind of what people looked at really in the beginning, and we'll go into that. And because you're doing less than anastomoses, you're doing a faster and often simpler operation and requires less conduit. However, the disadvantage, opposite to anatomic revascularization, is theoretically you may lead to more likely incomplete revascularization, especially in patients with very severe, complex multivessel disease. So let's jump into the history. We look here at the study from the Cleveland Clinic, about a decade of outcomes from the early days of coronary artery bypass grafting. I see a few familiar names here: Cosgrove, Loop, and Lido, who also published on the first few studies of the left internal thoracic artery to the LAD. And in their analyses, when they looked at complete versus incomplete revascularization, and they actually used a anatomic definition, they found that there was a signal showing that there's decreased survival in the incomplete revascularization cohort. This is back from 1979. Here we have a similar group coming out of Emory, and they also found that patients who had incomplete revascularization at 5 years seemed to have decreased survival. In 92, a sub-study from the CAS registry looking at coronary artery bypass grafting found that in their subgroup of patients with ejection fractions less than 35%, they found a signal. They didn't necessarily look at incomplete or complete revascularization directly. They used number of bypasses as a surrogate, and they found that the more vessels you grafted, the better patients did. And this is especially apparent in patients with EF of less than 35%. And then follow-up studies from the Emory group continue to find that even at the 10-year mark, this change was quite apparent. So then in 2002, there was a sub-study done of the Berry trial, the bypass angioplasty revascularization trial. And what they did was they tried to define incomplete revascularization in a few different ways. And so they assessed it using 4 different definitions. We can look at them here. So the first one they called it traditional. And this was the definition that most studies were using up to this time period, in which all coronary arteries with at least one significant lesion receive a graft. If you look at more detailed in the paper, this actually represents more of a territorial definition. And then they're functional, all disease primary coronary segments are bypassed, and this was equivalent to their anatomical. And then they looked at the number of distal anastomoses compared to the number of disease segments, and then they looked at the number of distal anastomoses to zones to the LAD as well as to arteries other than the LAD. This is just a schematic of what they considered different segments. And essentially what it is they have their main branches, and then the main sub-branches coming off of each main branch, such as the OM arteries and the diagonal arteries coming off the LAD. They found that there's no difference in survival between all 4 groups, except in one. And the issue is they did quite a few different sub-analyses. And so it's really hard to say, was this a product of them doing many, many analyses, or is this a real signal? But they suggest that the 7-year death and MI was highest when more than one anastomosis were performed in non-LAD targets. And they suggest that this was due possibly to the fact that this was a reflection of how severe the coronary disease was in this situation. And it was more reflective, not necessarily of the bypasses they did, but more so that these patients that did require all these bypasses to these non-LAD targets were just a reflection of how sick these patients were, or how more severe they were, and thus more likely to have worse outcomes in the end. So the bottom line was, we're not sure if we saw any difference between these various definitions, and possibly too many bypasses may be harmful, although this may be a bit of a stretch. More modern, and even though this is considered more modern, is from 2013, almost 10 years ago, a meta-analysis was done in both PCI and CABG trials. But looking at only the CABG trials, including a lot of the RCTs available up until that day, Syntax, Arts, as well as Mass, found that there was a 30% reduction in mortality as well as MACE for patients that had complete revascularization. However, as you can imagine, the definition of complete revascularization was quite different between all of these studies, but nonetheless, we saw this reduction. And then on average, incomplete revascularization was seen in 25% of CABG patients. In terms of randomized controlled trial data, we really only have data from the PCI world. And so many of you may know the complete trial in which they looked at subsequent stenting after STEMI to achieve complete revascularization, which found improved outcomes in these patients. And so this is now reflected in the 2021 revascularization guidelines, in which patients who have STEMI and remain stable, it's recommended to achieve complete revascularization. When it comes to CABG, however, there are recommendations in the European guidelines to achieve complete revascularization whenever possible. This is less defined as what is complete revascularization. And then from our North American societies, we really don't have guidance on complete revascularization and what constitutes complete revascularization. So just to remind everyone again, so anatomical revascularization will be revascularization of all segments of typically a predetermined size and at least 50% stenosis, whereas territorial, we're looking at the different territories or zones. And then we have score-based definitions of complete revascularization in which we calculate, for example, a residual syntax score with a high score reflecting more residual disease. And then different studies have used things such as completeness of revascularization index, which is calculated in several different ways depending on what studies used. But generally, they will either divide the number of anastomoses by the number of disease segments, or they'll subtract it. And so they'll come up with a number which reflects how much completeness of revascularization is achieved. And then we also have functional definitions, which looks at things such as fractional flow reserve or RFR, as well as myocardial perfusion testing to see what is the ischemic burden. So a few studies that looked at anatomic incomplete revascularization. We have a study from Europe here, which looked at a one-year sub-analysis in the ARCH trial from back in 2002. And they found that 1 year after bypass, there was no difference when you looked at the surgery group only in terms of complete versus incomplete revascularization. Moving on, we have a sub-study of the Syntax trial, a 3-year data, and they looked at a variety of outcomes, and this is only in the CABG arm here on the right side. And there was no difference in MACE, death, stroke, MI, or various combinations at the 3-year mark between incomplete and complete revascularization using the anatomic definition. Then we have a group from Washington in St. Louis, Washington University. They looked at a subgroup of just 80-year-olds and over. So they have 3 definitions here: total, complete, and incomplete. Total is their version of anatomical. Complete is their version of territorial, and then incomplete is when not even every territory gets a graft. And you see there's not a huge difference between total and complete, or anatomical and territorial. But if there is a territory that's left unrevascularized, these patients do quite worse. And in their multivariable analysis, they were able to confirm this. So just to summarize then, when we're looking at anatomic revascularization, there doesn't seem to be a difference. And then maybe in patients over 80, there is a decreased survival. Moving on to territorial incomplete revascularization. Our first group here from Cedars-Sinai found that using a territorial definition in their cohort, there was a difference in all-cause death as well as cardiac death in patients at the 5-year mark who are incompletely revascularized. This difference actually seems quite drastic, looking at 82% versus 52% survival. However, once they divided up into patients over and under 80 years old, this difference seemed to be more apparent in patients less than 80 years old. And we can see this on the right side here. Here's a group from Germany, and they also, using a territory definition, found no change. And there was no difference whether the circumflex or the RCA territory was unrevascularized. This is our group from France as well as Quebec, collaboration. And they found that after propensity matching, there was a difference in incomplete versus complete revascularization using a territorial definition. And this was seen to be driven by patients less than 60 years old. And this is after they've stratified by age. And you can see once you hit the 60, 70, and over 70 range, this difference is less pronounced. Here's some data coming out from our colleagues out east from Nova Scotia, and they found that there was a difference at the 10-year mark between complete and incomplete revascularization. They also interestingly found that the rate of incomplete revascularization was different by territory. This is actually documented in other studies as well. And it looks like when we look at incomplete revascularization, we're less likely to include the inferior wall, so they have the highest rate of incomplete revascularization, followed by lateral wall. And then the anterior wall is probably the most completely revascularized territory when you look at all studies of coronary artery bypass grafting. This study comes out from a large database study from the UK. And they looked at complete revascularization, and they divided by different territories and found that there wasn't a huge difference unless you left 2 territories incompletely revascularized. So if you left both the inferior wall as well as the lateral wall incompletely revascularized, you're more likely to see decreased survival up to 15 years. They also saw a difference between on-pump and off-pump procedures and found that the effects of incomplete revascularization were more pronounced in patients who undergone off-pump surgery. Finally, more recently, we have a sub-study coming from the RUBY trial, which was originally the randomized control trial that looked at on-pump versus off-pump. And they looked at patients who had 1-year angiograms afterwards, and then they followed them for 4 years. And using the 1-year angiogram to look at complete versus incomplete revascularization, they found that patients who are incompletely revascularized were likely to experience major adverse events afterwards, but this was mostly driven by repeat revascularization. So kind of just to summarize here, looking at the territorial definition, most studies did find that survival was decreased if patients were incompletely revascularized. And this is a bit different than what we saw in the anatomical studies, in which most studies didn't show much of a difference. Finally, a few studies to reflect other definitions of incomplete revascularization. This one comes here from Emory as well, from Dr. Puskis. And what they did was they looked at the index of complete revascularization, in which they divided the number of bypasses over the number of diseased vessels. Now, they also stratified by number of bypasses, and they actually found that there wasn't a huge difference between patients that received 1 to 3 bypasses versus 4 to 7 bypasses. And this is reflected both in on and off pump groups, as there are quite a large volume of off pump surgeries there. Now, once we actually looked at the index of completeness of revascularization, in this bottom line here, this is the group that had the lowest index. So this index was 0.25 to 0.75. What that means is patients who, for example, received 3 bypasses when there were 4 main disease segments, or patients who received 2 bypasses when there were 3 main disease segments, were likely to do worse than patients who had received, 1 bypass per disease segment, or even sometimes more than 1 bypass per disease segment. Now, this suggests that perhaps achieving complete revascularization through their definition matters more than the number of bypasses themselves. We have another study coming from a group in Italy that looked at residual syntax score. And what they did is in their cohort, they calculated the syntax score for all their patients, as well as the syntax score after they had done their bypass. First figure here just shows something that makes a lot of sense, in that patients who have a high baseline syntax score are more likely to have a higher syntax score after their CABG. And this is really just a reflective of how severe their disease is, in that even after you revascularize whatever segment or territory, there still remains a large burden of disease from a syntax algorithm standpoint. And they found, using a cutoff of 18.5, that patients who have a high residual syntax score are more likely to do worse. Now, does this say that this doesn't necessarily mean that these patients were more likely incompletely revascularized, but suggests that patients who come in with more severe disease are more likely to have severe disease afterwards, such as a score greater than 18.5, and are probably going to do worse from a survival standpoint. Finally, another study coming from a group in Ohio found, using their definition of incomplete revascularization, which I kind of mentioned before, they called it the CRI, or Complete Revascularization Index, another index. And what they did was they used subtraction in that the number of bypasses versus the number of disease segments. And so higher score, +2, kind of represents supra complete revascularization, as in you have more than 1 bypass per territory, which is similar to anatomical. And then you have -1 here at the worst end of the spectrum, which reflects that you've left at least 1 territory without revascularization. And as you can see, the patients with a score of -1 had worse survival. And when they looked at the hazard ratios in multiple different subgroup analyses, you see a very similar trend. Blue at the very top being patients who had supra complete revascularization, all the way to the bottom here, in which patients had truly incomplete revascularization. And you see this is reflected in all subgroups. And finally, we have the most recent study coming from a large database study, which looks at incomplete versus complete revascularization. They used inverse probability treatment weighting, a similar technique to propensity matching, in which they found that long-term MACE and mortality, more so MACE driven by repeat revascularization, was seen in patients who had incomplete revascularization. They also were able to look at one form of anatomical versus territorial by doing a sub-analysis, looking at whether when they revascularize non-main branch vessels versus main branch vessels, and found that there was no difference, suggesting that as long as you got the 3 large vessels, the LAD, the OM, as well as a PDA or PL on each territory, you are likely to achieve very similar effects as if you did all those bypasses. So to kind of summarize everything, we have a little bit of conflicting evidence, which adds to the mix of things. And so, why is this? Well, different studies use different definitions. We still haven't come to a consensus in our CABG literature in terms of what do we define as incomplete revascularization? This can be a matter of territory versus anatomical, functional. The degree of stenosis even is different between different papers, ranging from 50% or 70%. And this is obviously different in left main versus an LAD lesion. Difference in patient populations, as you can see, there are different studies that look at different age groups. Different treatments, so different papers will include on or off pump. Different centers will do different degrees of on and off pump. Different centers also use different degrees of multiple arterial grafting. And then the difference in period of follow-up. Some studies are looking as low as 1 year, and some studies are looking as high as 10, 15 years, where you're more likely to see a difference in outcomes in things like incomplete revascularization. And finally, as you may have noticed, all of these studies are retrospective in nature that look at complete and incomplete revascularization. And so you have a really high risk of confounding by indication for these patients. So, what we draw, the conclusions we draw from all of this data still remain in question, if you will. So what are predictors of incomplete revascularization? Well, at least from all of these studies, we know that we're likely to see incomplete revascularization in patients who are of increased age, patients who have higher comorbidity burden, decreased ejection fraction, patients that present with emergency or salvage status, high syntax scores, and often we see patients with off-pump CABG more likely to have incomplete revascularization. Technical reasons for why we might achieve incomplete revascularization. Sometimes the coronary arteries are too small, they're too calcified or diseased. Sometimes the surgeon assesses in the operation that this entire area is infarcted. We can see that the anterior myocardium is quite fibrosed and white. The artery may not be accessible. Once we see it in the OR, they may be very intramyocardial, or in the AV groove where it's simply not viable to do the bypass there. And then patients with multiple comorbidities with perceived decreased lifespan has influenced surgeon decision as well. And obviously patients who present in extremis are quite sick affect our decision whether we leave the OR with 3 bypasses or 5 or 6. So are there ways we can mitigate incomplete revascularization if we know that this may be the case going into it? So one of our colleagues out in Calgary, Dr. Kieser, who was kind of an early proponent of multiple arterial grafting, looked at 1,000 consecutive patients or grafts, and found that in these patients, when she compared incomplete and complete revascularization, she found that there was no difference. Now, when we look at her Kaplan-Meier curve here, there actually is a difference between incomplete and complete revascularization. And then when she stratifies by patients, she finds that this effect is less pronounced in patients less than 80. And then when she actually factors in using a multivariable analysis, she finds that there's no difference between or in patients who are less than 80 years old. And so she postulates that this lack of difference in incomplete and complete revascularization incomes is offset by the fact that she's using complete arterial revascularization in this patient population. More recently, a group that looked at their database found that midterm outcomes that multiple arterial grafting matters a bit more than incomplete revascularization. And so they stratified their patients by single versus multiple arterial grafting, but then also they stratified by incomplete revascularization and complete revascularization. And so you can see in this survival curve here that patients who receive single arteries are both at the bottom here, and patients who had multiple arterial arteries, multiple arterial grafting are at the top here, and that this includes both incomplete and complete revascularization in kind of both groups here. And so what matters perhaps more is that patients received another artery rather than whether they're incompletely or completely revascularized. So what's the verdict? If we go back to our patient with this heavy burden of coronary disease with multiple risk factors, what did we actually do? In this case, this gentleman actually received the anatomical bypass grafting. A lot of it surgeon preference, and they continue to do well. And then how do we make sense of this data? Because looking back at it, perhaps they would have done well with a territorial definition as well. The answer is we're not too sure. So kind of to bring it all together, we should at least aim for territorial complete revascularization in everyone, and perhaps anatomical revascularization in some populations. We know that anatomical probably is not harmful because we don't see any signal for worse outcomes, at least in the studies that have been done so far. Emergence and salvage patients probably benefit from a simpler operation. I think the goal here is to get them out of the operating room alive, rather than with something that we anticipate will help them 10 or 15 years down the line. We think that maybe multiple arterial grafting may matter a bit more than completeness of revascularization. However, the data here is sparse, but we do see trends that the lead to LAD, as long as there's that graft, then what we do in terms of revascularization in the other territories might matter not as much. But I don't think there's conclusive data yet to suggest that. If we're unable to achieve complete revascularization right off the bat, then I think it's totally reasonable and in fact encouraged to try and consider a hybrid approach in which we do minimally invasive or mixed surgery for the lead to LAD and then PCI to the other vessels. Furthermore, we need to get more data on patient-centered outcomes, such as quality of life, as well as angina scores, as this may be what we see as the benefit from anatomical versus territorial revascularization. However, this just hasn't been studied yet. Going back to our basketball example, in 2019, when we were able to defeat Steph Curry, ultimately what worked was, well, a little bit of luck because they had a few injuries on their team, but really our ability to adapt to what was given. And so we didn't use just a zone defense, and we didn't just use a person-to-person defense. We mixed it up, and we used a bit of both, and then we used a combination of both. And I think this is very reflective of coronary artery bypass grafting practice. We don't just look at the angiogram. We look at what's given to us in terms of patient presentation, patient comorbidities, patient age, what is the availability of conduit, and then we modify our strategy based on that. And that seems to work so far. In terms of looking to the future, other ways that we can look at revascularization. Here we have a table from one of our previous fellows that looked at, that summarized the data on FFR-guided revascularization. So far, there hasn't been any conclusive data to suggest that FFR-guided revascularization is better than angiographic-guided. And this is looked at in the Fargo and the Graffiti trial. We'll see what the other outcomes come out of this after the 6 and 1 year mark. But we do have some evidence that some of these FFR-guided trials, such as the one Dr. Glenier did with the IMPACT trial, may be able to give us numbers such as cutoffs for when we should employ certain revascularization tactics, such as sequential grafting. And this comes out of the group in New York, Greg Stone and the group, looking to standardize the definition of complete revascularization. And I think this is a step in the right direction, in that we do need to come with a more standardized and harmonized definition of complete revascularization if we're to come to any conclusions and make any recommendations from that standpoint. And so they've come up with an algorithm, and this algorithm is probably not perfect, but it is, they are starting to bring up the idea that this is something we should look at and we should consider adopting. And so I think on this paper, actually, there's no surgeons, but I do think that this is an opportunity for collaboration between, interventional cardiology and cardiac surgery to come up with, what do we think are definitions that we should use for complete revascularization so that we can better study it and come with more consistent studies as well as consistent outcome measurements so that we can, in the end, come up with what's best for our patients. So really just bring it all together. Two main philosophies to revascularize, whether it's territorial or zone versus anatomical. And then the definitions remain, have previously been inconsistent, which lead to inconsistent outcomes. We think that territorial should probably be the bare minimum that we aim for in terms of completeness of revascularization. There may be a role for incomplete revascularization, which is considered reasonable in sick patients. And then maybe anatomical revascularization may provide higher yield in younger patients, as we've seen that this subgroup tends to benefit. Thanks a lot for everyone for your attention. Thanks to Dr. Glenier for his oversight in this presentation, as well as the rest of the division for their help as well.